Hello, everyone. We are pleased to have you join us for Cardinal Health Lab Exchange. Welcome to today's live broadcast, The Future of Laboratory Reimbursements. I'm Bob Woodard of LabRoots, and I'll be your moderator for today's webinar. We are delighted to bring you this educational web seminar presented by LabRoots and sponsored by the American Society for Clinical Laboratory Science. The mission of the AFCLS is to make a positive impact in healthcare through leadership that will assure excellence in the practice of laboratory medicine. For more information, please visit afcls.org. We have a few important announcements before we begin. This webcast is designed to be interactive, and we encourage you to ask questions during the event. You can submit questions by typing them in the Q&A box, which can be found by clicking on the green Q&A button at the lower left of the presentation window. We'll try to answer as many questions as we can. You can enlarge the slide window by clicking on the screen icon in the lower right-hand corner of the slide window. Finally, if you have any technical problems viewing or hearing this presentation, please click on the support button at the top right of your presentation window or submit your problems to the green Q&A button on the lower left. Following this presentation, head over to the Community of Learning in the Lab Exchange lobby to have the opportunity to engage in live chat and have more of your questions answered on the spot about the future of laboratory reimbursements. I would now like to introduce today's speaker, Elissa Passiment. Ms. Passiment is the Executive Vice President of the AFCLS. She is a clinical laboratory scientist with over 20 years' experience in clinical laboratories as staff, educator, and manager, and another 20 years in healthcare consulting, association management, and health policy. Ms. Passiment uses her science background and experience to analyze policies and systems as they relate to the future of healthcare, its changing emphasis, reimbursement, patient safety, quality delivery, and business potential. She has served on the congressionally mandated Negotiated Rulemaking Committee convened to standardize and simplify reimbursement for laboratory services under Medicare Part B, presented testimony to Institute of Medicine Studies, and represents AFCLS at meetings with the FDA, CMS, and CDC. She is also on the editorial board of Lab Tests Online. She was a member of the Clinical Laboratory Improvement Advisory Committee from 2007 to 2011 and served as chair from 2009 to 2011. Please join me in welcoming Ms. Passiment to today's event. I will now turn the presentation over to her.
Thank you, Bob. Good morning, everyone. We're going to spend the next 50 minutes talking about what is going on, not only in general terms, but also in very specific terms as far as reimbursement for laboratory services, and then some of the regulatory issues that you're all going to be or are currently confronting. It's very important that we keep up with all of this because you just never know frankly, from day to day, what is coming next from the federal government. The critical issues that are affecting all of us these days include changes in practice that we're all facing because of the structure of healthcare. Healthcare is moving to accountable care organizations and medical homes and other configurations that don't always include the traditional settings that we think of for practice of healthcare. We're looking at different concepts for reimbursement. This is in particular of major concern to those of us in the laboratory. We're used to being reimbursed by test, and that is something that, as we will discuss shortly, is probably going away. We're all faced with a personnel shortage of one sort or another, and the way you're coping with it may or may not be ideal, but it may be what you're doing because you have no other choice. There are some clear regulations, some that have changed, some that will be changing. And then at the end, we'd like to talk a little bit about the FDA's guidance on laboratory developed tests, and also, if we have time, the blood glucose monitors. So looking at changes in practice, one of the first things that have hit all of us is the patient access to laboratory test results. This is something that if you're as old as I am, we've talked about or been told forever not to give patients information about their laboratory tests, and that is all changing. As healthcare has become more patient-centric, the laboratory and its services are one of the last to open or be opened to direct contact and communication with patients, but it has now happened. The HIPAA and CLIA regulations were both modified 2 years ago to mandate that patients get their laboratory results if they request them. There are patient-centered care is being extended with the concept of medical homes, and frankly that means at some point we're probably going to find ourselves hooked to these medical homes. These medical homes, the way they qualify is that they are responsive and available to the patient on almost a 24/7 basis for consultation. If we're going to be part of medical homes, it means someone from our laboratory is going to need to be able to talk to either the physician or the patient and talk about the laboratory test services that they need or have already had. And then there are patient safety initiatives that the Joint Commission has been particularly forthright about, and then evidence-based medical practices, which we provide the evidence for. So the future of CMS is that they're talking about coordinated care models, and the reason that they're talking about that, and we have to pay attention, is because they're going to want to do reimbursement around those coordinated care models. So Medicare Advantage or Medicare Part C, depending on how you refer to it, those insurance companies that contract with Medicare to cover beneficiaries was their first foray into coordinated care. Accountable care organizations and medical homes are their most current, and they have and always will talk about episodes of care, trying to get their arms around what would be the definition of a set of services, or what would it look like, this set of services that are provided when a patient starts an episode, has a clinical condition that makes them present to the healthcare system. And frankly, CMS is thinking that, is there a way, just like they did with DRGs, is there a way to pay for the episode in some sort of lump payment that then gets divided among those who gave care to the patient? The future is probably the fee-for-service as we know it, that is being paid for what we do on an piecemeal basis, is probably going to go away, and that some sort of quality measures are going to be used to decide the value of what we did and how much reimbursement we are due. The physicians have already put together quality measures that have been developed by their various associations to determine what should be used to measure the quality of the care that they delivered. And the question is, should the laboratory community come together and do the same thing? Obviously, it probably would be wise if we did, if we were proactive, because if we wait, it's going to happen to us. The discussion is that they're going to phase out fee-for-service. Physician groups have called for this phase out, and CMS has been searching for a new approach. If there are any of you out there who are currently working in ESRD laboratories or laboratories that work with end-stage renal disease patients, you know that you have already been part of a demonstration project that linked payment to the dialysis center's ability to provide quality care and meet certain quality measures, and that your laboratory reimbursement got bundled with their quality measures. CMS has announced that they are planning to move away from fee-for-service and to other types of payment models. They keep talking about value-based models, which they have not really defined well yet. And then the bundle payment models, the one that we know the best is DRGs for any of you who have to deal with inpatient reimbursement, but they are looking to apply that bundle payment model to reimbursement for any, regardless of where the care is given in the health system. The payments will be based on quality and some sort of coordination of care. And we in the laboratory, we hold the information necessary to really make sure that care is coordinated, because we have the IT systems that can bridge both the care setting in the physician's office, the care setting in a clinic, or even an urgent center with the care given on an inpatient basis. Our IT can talk to all of those settings better than just about anyone else in healthcare. And if your IT can't do that, it needs to get started doing that really quickly, because the tools are out there already for lab IT to do that. And so we hold the keys to that coordination, but unfortunately, we're not always well recognized for that. So our current strategies of just trying to keep costs down by increasing volume to get better margins for our fixed reimbursement are not going to work if we're not going to get reimbursed by the test itself, but rather by some other quality measure. So at the beginning of 2015, HHS, Health and Human Services, made an announcement that they were going to tie 30% of the traditional fee-for-service Medicare payments to some sort of quality or value payment models, such as what they were doing with the ACOs, the accountable care, and that there would be bundled payment arrangements for some of this traditional fee-for-service by the end of 2016. That is not that far away. They want to tie 50% of all payments to these value models, value-based models, by the end of 2018, and 85% of all traditional Medicare payments to quality or value by 2016, and 90% of all hospital readmissions or a hospital reimbursement to programs like value-based purchasing and readmission reduction programs by 2018. There's an additional goal to tie 85% of all traditional Medicare payments, which is what we fall into, by 2016. So that means we are going to end up finding ourselves with involved in new negotiations, negotiating things like what's the definition and the measurements or metrics that are going to be used to determine that we provided quality service that allowed the institution to meet its quality goals. And then based on what we show them we did, we have to negotiate some portion of that total reimbursement, because the hospital or the ACO is going to get it. We're not. That's what happens with these bundled value-based payments. It's given to whatever is considered the parent or the controlling institution, and then they are supposed to disperse it based on whatever formula they come up with. And so you, each of us at our individual institutions are going to have to spend the time to determine or help our C-suite determine how much of that payment that they receive comes to us, gets charged to our accounts so that we have the dollars to pay our folks and to keep the doors open. That's what's coming down the road. But the current reality is that laboratory testing is a small part of Medicare spending, but our payment amounts have been reduced by over 40% over the past 2 decades. Most recently, since 2011, we have seen cuts to the CPI, which is the Consumer Price Index, that we're supposed to get updates from. We got a 2% cut when Congress passed the Middle Class Tax Relief and Job Creation Act, and it also got rid of the technical component for pathology services, which was definitely took a your pathology department took a hit for that. And then there was a 2% cut to the fee schedule as a result of sequestration that began in 2013 and happened again this year in addition. So the American Association for Clinical Laboratories, ACLA, has put together a graph to show Congress and anyone else who will listen what has happened to our reimbursement since 2010. They took a sample $10 test and showed the blue line that you see going straight up is what should have happened if we had gotten all of our updates and nothing had been frozen and we had never been cut. So by 2022, that $10 laboratory test should have been reimbursed at $12.84, but even here at 2015, we should have been being reimbursed at least $11 and maybe $11 and change. However, thanks to all the different cuts that occurred, and they're represented by the different colored lines, the bottom line is that, and that is the very bottom, is that by 2022, that $10 test is only going to be reimbursed at $9.83. And even as of today, that $10 test is already been cut, so we're only getting $9.14 for it. So there are no other healthcare providers in the system that have received this level of cuts, and that's why we keep telling Congress they can't keep doing this. However, the OIG in 2013 identified, they believed, that we had been Medicare had overpaid for laboratory testing to the tune of billions of dollars. They looked at how Medicare was paying versus Medicaid, which, by the way, by law, has to pay less than Medicare. So that's really not a fair comparison. And then selected some insurance companies, most of which were the federal government employees insurance companies and the military insurance company coverage, which again are typically reimbursed at much less or no more than Medicare, and did not look at any of the private third payers that most of us have to deal with, the Uniteds, the Cignas, et cetera. So we believe that they cherry-picked a couple of insurance companies to make a point that wasn't really valid. It was a flawed study, but unfortunately Congress believed in it. In addition, they just announced that as part of their 2015 work study, this is a piece of information that just came out, they will be looking at lab payments for the top 25 tests that Medicare paid for to determine again whether or not Medicare is overpaying. And this is not going to help when we all try to talk to our individual institutions and try to get some of the dollars that they're going to be getting for value-based payment. So the issues that we're facing is the Protecting Access to Medicare Act and what happened there, and I'll explain that in a minute. The CMS HOPS program, that stands for Hospital Outpatient Prospective Payment System packaging of laboratory tests, the molecular pathology reimbursement, and any of you who are part of that know what a pain that has become. CLIA updates, and then, as I mentioned earlier, patient access. So the current reimbursement, under the current reimbursement, CMS was packaging a lot of tests services that were delivered to outpatients and paying the hospital, and the hospital was then determining how the money was doled out. Laboratory tests and some pharmaceutical and radiology tests were all excluded from that initial bundling. But in 2013, they announced that they were going to be doing that, and they have done that. At the end of 2013, CMS published a rule that implemented a new policy that packages all outpatient laboratory tests provided on the same date of service as the primary service, whatever the patient presented them to the primary care doc for, and ordered by the same practitioner who ordered the primary service. And the only thing that they carved out of this was molecular pathology. because they believed that they had already adjusted the reimbursement for molecular tests and that could be held separate. And that also most molecular pathology would not be considered a laboratory test that was ordered for a primary care service. We explained to them that there's very little that outpatients come to get in the way of laboratory tests that are strictly for primary care, that most of the time they are coming as outpatients for some existing syndrome and that it's being followed on an outpatient basis. But CMS did not buy that explanation. What they did do, though, was give some exceptions. First of all, they said that they believed that this was going to moderately reduce payment to rural and major teaching hospitals because they weren't going to get separate payment, and that it was for primary care, even though, as I mentioned, we contended that outpatient visits are rarely for that reason. So they carved out some exceptions. If the patient is a non-patient, that is not a hospital's inpatient or outpatient, then you can bill for your laboratory services. If the specimen was collected by the hospital for lab work only and the patient got nothing else done that day, again, you can bill. And if the laboratory tests were clinically unrelated to the reason that the patient went to the presented for outpatient services, then again, you could bill separately. And so far, CMS is defining unrelated as a test that's being ordered by a different practitioner for a different diagnosis. And this is causing a great deal of confusion. I'm sure some of you are struggling with this. The other thing that they came out with that we're all struggling with is the molecular test coding. They decided that, the stacking codes were too confusing and, they didn't know what they were paying for. And so the AMA CPT committee came up with new codes. CMS embraced those codes and said that they were going to divide them into two categories. Tier 1 were going to be codes that they believed were for analytes that are done a lot of a high volume, and then Tier 2 were codes that were for lower volume. And that payment levels that they then assigned through their contractors for most of these codes turned out to be very, very low and very difficult for any of us to do the molecular testing with because they weren't covering our costs. We also questioned the transparency of the coverage decisions because they really didn't give us an opportunity to make much comment. They asked for our input as to how much things were costing us. We gave them those numbers, and yet the reimbursement numbers that they came up with bear no resemblance to the cost that we submitted. So we can't figure out if they've got calculators that are missing a couple of numbers or periods or what's going on here, but they don't seem to know how to do simple math. The other concerns is that Medicare seem to be assuming that there are some tests which admittedly are primarily performed in the pediatric population that would never be used for individuals covered by Medicare, and therefore they're not paying for them. The problem with that is, as you all know, Medicare also covers individuals who have permanent disabilities or are on renal dialysis. So any children on renal dialysis or who are permanently disabled are covered by Medicare and are therefore not getting the tests that they need, the molecular tests that they need. In addition, because Medicare is not setting rates for those tests, the Medicaid programs think that they shouldn't be paying for them either, even though the tests do apply to their pediatric population. So we've been trying, along with the Association for Molecular Pathology and CAP and others, to get meetings with the medical directors of the Medicaid, the state Medicaid programs, to explain to the Medicaid medical directors that these are appropriate tests for the pediatric population and they do need to be paid. That those efforts have been not as successful as we'd hoped, but we keep working on it. The other thing CMS announced was that they were going to set new rates for the clinical laboratory fee schedule because they believed that there was a need that they were overpaying for many laboratory tests because of the advances in technology. They were going to do a 5-year process, and the idea was to reduce payments. The laboratory community was not delighted because we felt they were going to do this without getting our input or use those same weird calculators if they got our input, and so we needed a legislative fix. During the AFCLS Legislative Symposium, which we do with CLMA, AFCP, AMT, and AGT, we went up to the Hill and talked to them about that. At the same time, separately, ACLA and AdvaMed Coalition was also on the Hill saying, you can't let CMS do this. And as the Congress passed the Protecting Access to Medicare Act, affectionately known as PAMA, they included in that a clause that said that beginning January of 2016, all applicable laboratories will send the Secretary of Health and Human Services data about what they have been paid on fee-for-service from all insurance companies, regardless of the insurance company and regardless of the payment arrangement, and that the Secretary could establish an exclusion for any small laboratories or laboratories who only were paid very small amounts on fee-for-service. That is, all of their work is capitated, that sort of thing. So those were things that the Secretary and HHS were supposed to do in regulation. The Senate clarified that when they said all applicable labs, they meant all independent labs and all hospital outreach laboratories that receive payment on a fee-for-service basis, because there was some question about whether or not they really meant that hospitals had to respond. CMS was going to take the data. They were going to do a weighted median. Now, keep that in mind, not a weighted average, but a weighted median, which, as you know, means they're just counting into the center. The problem with that is if hospitals don't supply data and the number of N's, the number of pieces of submitted data are primarily supplied by reference laboratories, the weighted median is going to be very low. So we have a lot of concerns about making sure that CMS provides a way for hospitals to submit the data, since it's way more complicated for them to do it than it is for a reference lab to do it. Theoretically, then, the CMS would then crunch the numbers, and by 2017, we would be paid on this new weighted median for all the tests on the clinical laboratory fee schedule. The payments amounts would be determined this way for 2017 through 2022. They were not allowed to reduce the payments more than 10% for the first 2 years and then 15% for the next 3 years. Not really exciting news, guys, because you're talking about a 25% reduction by the end of 2022, which is even worse than what we were expecting initially from our current cuts. Oh, and just so we could feel better, I guess, about this, they gave us an increase in our collection fees if we went to collect from a nursing home or an off-site of $2, and up from the regular $3, so now we can get $5 for that. I wouldn't be buying any new equipment based on that, but that, And the payment for new tests would be determined by either crosswalking or gap filling. Crosswalking means they would take a look at a test that's already exists on the fee schedule and see if it matches, and if it does, that's how you would get paid. And if there was no existing test, then they would do a gap filling, which is when we submit information about how much it costs, and they're supposed to calculate the new payment. They also carved out or described a category of advanced diagnostic laboratory tests for which they would pay whatever the laboratory decided to charge for 3 quarters. And then in the 4th quarter, they would take a look at what everybody was charging for that test And if the test exceeded some weighted volume that they had calculated, then CMS was going to ask you to give some money back. They defined advanced diagnostic laboratory tests as tests that are offered and furnished by a single lab and are not sold for use by that lab other than by the original developing laboratory, and are cleared by the FDA. Most of us are scratching our heads trying to figure out what test that might be, but CMS seems to think they know. They also were supposed to establish advisory panels, and those advisory panels were supposed to help us. We were supposed to be able to give input to CMS to help them make some decisions about the data they were getting and how to do the calculations. And we've all submitted nominees to these advisory panels. Those advisory panels are supposed to meet as of July 1st. To date, they have not announced any of the names of the people that have been appointed to the advisory panel. The PAMA was also supposed to establish payment rates for all tests, and then the General Accountability Office was supposed to study and submit no later than in October of 2018 an assessment of what the impact of all of the implementation of these new levels of reimbursement had on, we're hoping, laboratory services and patient access. And then the OIG, again, was supposed to analyze Medicare spending on the top 25 tests every year. So the OIG has taken that part of PAMA to heart, and that's why they announced that they're going to be doing that this year. They believe that that's their authority to analyze the Medicare spending going forward every year, but CMS has still to publish any of their part of the regulation. And in the meantime, PAMA still let all the cuts stay in effect. So while reimbursement is currently up in the air because we have no idea when CMS is going to start this project, how we're supposed to submit any data, when all of this is going to be implemented, because we've not seen the regulations. In the meantime, we also have other regulatory challenges that we will be facing. FDA's guidance on laboratory developed tests, CLIA's proficiency testing, CMS is concerned about how many waived tests are out there, the personnel issues, and patient access. As far as patient access, you are all at this point required to give patients their designee access to laboratory test results 30 days, no more than 30 days after the completion of the test. And CMS has made it clear that you can't arbitrarily just wait 30 days if the test result is available earlier than 30 days. I'm sure all of you have figured out some way to do this. You are allowed to let your medical records department handle this. You don't have to handle it. But if you are handling it, you are also allowed to charge. Okay, now the other thing that CMS is worried about, and it's shown on this slide, is the personnel issue. They believe that they are seeing in laboratories that they are visiting for inspections a shortage of educated personnel, that the hiring practices where laboratories are hiring individuals who are not appropriately educated and certified is raising concern for them because they don't believe that these folks necessarily know what they're doing. They are concerned that over time there is going to be a great deal of pressure on the existing personnel to perform the way they need to. And if that is the case, that those pressures could lead to patient safety compromises somewhere along the line. In addition, CLIA has also taken a look at proficiency testing. They are working on modifications of the current proficiency testing regulations that are in the regulation because they are incredibly outdated. However, they have been looking at this since 2009 and have not been able to come up with the language that they believe will work for not only today but in the future. So there's a real concern for many of us that we're wondering when and if they're going to ever get updated proficiency testing requirements out there. But they have also looked at quality management and the electronic health record initiatives and the laboratory's role in meaningful use requirements. Okay. So as far as proficiency testing, the other aspect of proficiency testing that has been an issue for CMS and for many laboratories is the possibility that laboratories, either accidentally or on purpose, referred their proficiency testing samples to another laboratory for testing and then reported the results that the other laboratory did. The old CLIA regulations required that if CMS found out that a laboratory, for whatever reason, referred PT testing, they had to close that laboratory or suspend its license, which is the same thing as closing it, for 2 years, suspend the license of the laboratory director for 2 years, and the laboratory would not be allowed to do any Medicare testing. That was, by CMS's own accounting, too strict. And with CMS's blessing, the laboratory community went to Congress, and Congress passed the Taking Essential Steps for Testing Act, known as TEST for short, which gave HHS the discretion to figure out new sanctions, okay, for PT referrals. CMS issued their rule, and that's the website where you can find the rule, and it divides the sanctions into 3 categories based on what they consider to be severity. So the first category was the laboratory purposely sent their proficiency testing sample out. In that category, if it was done for the first time or whatever, they would revoke the license, suspend the director for at least a year. The second category was if they referred it out and received the results prior to sending in their answers, but this appears to be the first time they ever did that, then they could suspend and impose alternate sanctions for less than 1 year. But they would still probably suspend the laboratory director. The third category, where the test results were sent out, but the results were sent to the proficiency agency before they received the results from the referring laboratory, that category would just get alternate sanctions. Each category would be subject to civil money penalties that typically started at $10,000. The alternate sanctions always included required retraining of the staff, but the concerns were that this rule still wasn't flexible enough and did not meet congressional intent. However, that is currently what we're working with. There are some valid reasons or opportunities where a laboratory will accidentally send out a proficiency test sample because, A, you're supposed to be treating them like patient samples, so theoretically your staff doesn't know it's a proficiency testing sample. And if it is something where, let's say, you get one result and then you send it out for further testing, you would send out the proficiency testing sample. Theoretically, your quality management supervisor or whomever that person is would stop the sample before it goes out the door, but sometimes those things don't happen that way, and that's why there is a need for some flexibility, and we're hoping that CMS will continue to, how should we put it, use some discretion when they look at what a laboratory has done to make sure that they're not suspending laboratories that really did something totally by accident. As far as electronic health record is concerned, CMS and CDC are very concerned that laboratorians are not being engaged well enough in the design of the regulations for meaningful use, and so they have asked all of us, all laboratory associations, to raise their concerns with you all and to ask you, as the opportunity presents itself, to volunteer to work with whatever federal agencies or meaningful use projects are occurring in your institutions, because otherwise there are going to be decisions made that will not be appropriate for how laboratories' data interoperability works. The next thing that CMS did do, CMS CLIA did do, was to look at the EQC policies. They participated in a process with CLSI, the Clinical Laboratory Standards Institute, and decided they were going to replace the EQC policies that everybody said were not very good policies anyway, with this IQCP, which stands for Individualized Quality Control Plan. This is a voluntary thing that you can do. If you are doing EQC, if you've used EQC for any of your tests, be it point of care, be it wave testing in your laboratory, that has to be replaced with something. So you have two choices. You can default to the current regulations, which say that there has to be a minimum of 2 levels of external control per day of testing, or you can try to implement an individualized quality control plan. CMS provided interpretive guidelines. I have supplied you with a link to those. These interpretive guidelines are used to clarify and explain regulations and convey the agency's thinking, and that's what they have done for IQCP. What they want you to do is develop your own QC plan based on the risks of failure that you believe you have identified in your systems. You might start with some routine test or some very low volume esoteric test. There has been an education and transition period that has been going on for the past 1.5 years. It will be over in the next 6 months, and then anyone who was using EQC must either go back to the default regulations, as I mentioned earlier, or must have an IQCP plan in effect. It's meant for non-waived and certified labs. There is an email box where you can ask them questions about how to do this. The deemed organizations are supposed to incorporate this into their regulations however they see fit. So if you are inspected and accredited by either CAP or Joint Commission or COA, you follow what they want you to follow, and you don't have to worry about this. But if not, the CMS has actually published a step-by-step brochure giving instructions on how to implement an IQCP plan on their website on the IQCP pages. So if you just go to CMS and look up the IQCP page, you will see brochures explaining IQCP and then also a step-by-step guide for implementation should you decide to do that. Laboratory developed tests are the next thing that will be of concern. For many of us, we don't believe we do laboratory developed tests, but depending on how FDA decides to define laboratory developed tests, we may all be doing laboratory developed tests and not knowing about it. The agency is really concerned most of all about companies that decided to form laboratories to get around submitting their new products for FDA clearance and instead call them laboratory developed tests. And they believe that there are tests out there that have not been, whose clinical validity and clinical utility has not been proven or established. And there are laboratory professionals, AFCLS's members are among them, that do share concerns about the clinical and analytical validity of some of these laboratory developed tests. FDA held a 2-day workshop, and the patient groups that attended all urged FDA to implement their authority and figure out what's going on with these tests, because patients are being told that this tumor marker or this genetic marker means that they should get or not get a particular drug therapy, or that this tumor marker or that genetic marker means that they are prone to relapses or prone to metastases. Some of them have turned out to not be true, others have been true, and they believe patients are being misled and confused. On the other hand, the large laboratories believe that this is going to be an onerous burden for them, and they have been lobbying Congressman Burgess in particular to remove FDA from oversight for laboratory-developed tests. CMS opposes this because CLIA says they don't have any expertise to determine clinical validity. That's not what CLIA does. We've all been asking CMS and FDA what is their definition of a laboratory-developed test, because all of us, over time, tend to modify our laboratory tests. We play around with pH, or we play around with a different specimen type, and we do the validation studies that we know how to do per CLIA, and believe that we have not done any particular harm to an FDA-cleared test. FDA's definition seems to say that those modifications may require that we submit the test for FDA clearance, and that is something most of us do not have the capability of doing. There's a lot of concern about what will happen if this is not done properly. It will stifle innovation, and it certainly is going to slow down what happens with genetic testing. So this is another area that we are watching very, very carefully. FDA is supposed to be releasing the next round of guidance. We don't know when that's going to happen. We hope it will happen sometime this summer or fall. In the meantime, FDA and CMS are meeting together and are going to crosswalk what CLIA does and what FDA's clearance process does to determine where there are overlaps, so that if laboratories do have to submit any of their laboratory-developed tests, they will not be having to duplicate effort between the two sets of regulation. That was just announced in March, and that effort is ongoing. We're waiting to see what that looks like. The other thing that FDA raised major concerns about was glucose monitoring. They issued draft guidance on self-monitoring devices that are used at point of care. Their concerns were two, that first of all, individuals using these glucose monitors at the point of care typically were nurses, LPNs, maybe even patient care technicians. It was not the patient, and they were using them between patients and not cleaning them properly, causing infections to be transmitted from patient to patient. They had documentation of that. And then also that there were instances where drugs that were in the IVs of the patients who were being tested by these glucose monitors interfered with the test strip, gave erroneous results, and patients were treated inappropriately, and in a number of cases there were deaths that occurred. Hospitals have been concerned about the guidance because it seems to remove wave status from glucose meters. And in essence, that is what would have happened. FDA believes they should be considered moderately complex tests and therefore need to be proficiency tests. At the same token, and you don't have this on your slide, what happened was, the FDA CMS issued a memo that said, if you are using those point-of-care waved glucose meters on critically ill patients, they are considering that off-label use, and it becomes a high-complexity test. Now, CMS has since rescinded that memo, but to add to the confusion, kids, what they're saying is, while we rescinded the memo, the intent is still there. And when we questioned CMS about that, what they basically told us is what we mean by that is that you still have to start to quality control and be careful about who's using those point of care glucose monitors, because we don't consider using them on critically ill patients to be approved usage by the label. So, FDA has said that they want to see the manufacturers resubmit their meters to show whether or not the meters can be used on subjects who are in critical care settings, who are receiving IVs and other drug therapies, multiple different kinds, to determine what happens to the test results depending on what might or might not interfere, and that when that labeling changes, then FDA will reconsider how to classify the devices. All of this is very ongoing at the moment. If it is what AFCLS has been telling its members is, if this is an issue in your hospital, at this point you should be at least re-educating everybody who's using those point of care devices and doing major validation studies for drug and IV therapy interferences. If you cannot undertake that, then the odds are good you should figure out another way to test patients' glucose at the bedside besides using those glucose meters. At this point, we can stop for questions. I see that there are some questions. Let me take the first one. Is the gap on payment reduction 10% for 2017 and to 2019, or 10% for each year? Excellent question, Todd. We've asked that question because we don't know. One group of us has read that as it's 10% for the collective years, and another group has read that to be 10% each year. So in other words, for 2017, 10%, for 2018, 10%, for 2019, 10%, and then 15% for 2019 through 2022. If that really is the right interpretation, we're going to be paid nothing by the end of 2022, just about. So we're all hoping that the initial interpretation is the correct one, that it's 10% for the first those 2-year gap, and then 15% for the next 3 years. But we don't know for sure. And again, we were hoping that when CMS issued its regulations, they would clarify that. The regulations have not been clarified, have not been published. The next question that I see is, can you elaborate on EQC and IQCP and when we should start applying them? Okay, so EQCP is equivalent quality control, and that has been in effect and had been in effect since 2010, when CMS first rolled out this new concept of doing what would be considered more efficiently structured quality control. So you didn't have to do quality control every day. They rolled this out, but unfortunately they rolled it out without a lot of scientific studies and no evidence to explain how they came to the decisions that they came to. And they said if your system was very, very stable, you could actually not run quality control for a month if you could prove that the system was stable enough. But they didn't say how you were supposed to prove that exactly, except that you had to show them validation studies and that sort of thing. And so the community at large was concerned about this whole EQC concept. And that's when CLSI stepped in and held a set of meetings and said, what else can we be doing? How else can we look at quality control? And they started talking about looking at quality control based on the risk of something failing in your system, the risk of the incubator temperature changing without you knowing about it, the risk of not enough reagent being delivered for a given test, all those kinds of areas where your system could fail on an instrument. and then quality controlling that area rather than quality controlling just in general with the 2 levels every day of testing. And that's how IQCP was born. It came from one of CLSI's documents called EP23. IQCP and EQCP were both voluntary. They are not mandated by regulation. You didn't ever have to use them. You could have just done your 2 levels of quality control every 8 hours or every day of testing like the regulation says. But if you don't want to do that, if you want to be more in control of your own quality management system, then you can no longer use EQCP. You have to develop your own IQCP program. You have to have it in place by the end of this year, because starting in 2016, if you decide you don't want to do what the regulations say to do, which is to run, and I keep repeating this because I want you to understand, you have a fallback. You don't have to do IQCP. You can just do what the regs say and run quality control, 2 levels of external control every 8 hours or 24 hours, depending on your testing. If you don't want to do that and you want to do something different, you have to follow an ICQ process, and you have to have that plan in writing available to inspectors when they come to see your laboratory. And that's what CMS has posted on their website, this step-by-step guidance as to how to implement that if you so choose to go that route. I hope I answered that question. If that didn't, please ask another question now, or we can talk about it when we're in the alternate site where you can ask more questions. Are there any additional questions?
Okay, well, I guess if there are no further questions at this time, well, thank you, Elissa, for that informative presentation. I'd like to thank our sponsor, AFCLS, for making today's webcast possible. And I encourage everyone to head over to the community of learning following this presentation to have the opportunity to engage in live chat with Elissa Passiment and your peers and have answers to any questions you may have about the future of laboratory reimbursements. As a reminder, today's webcast will be available for on-demand viewing through October of this year. You will receive an email from LabRoots alerting you when this webcast will be available for replay. We invite you to forward that announcement to your colleagues who may have missed today's live event. Thank you very much for attending, and we'll see you next time. Until then, goodbye.